Well, thank you. And that was very heartwarming. It's always nice to be appreciated. And I appreciate being invited back year after year. And looking forward to when I can be in the same room with everybody. But this works pretty well too. It's turned out you guys are great. I mean, this is great what you do technically. So today we're going to talk about Parkinson's disease. And as the little video that preceded my coming in mentions, we create courses both for consumers and healthcare providers on conditions ranging from kidney stones to stage 4 cancer. And interestingly enough, the courses are the same for consumers and healthcare professionals. One thing, and I think many of you have figured this out, people are much more interested in their health, consumers are, and knowing the source of disease and what they can do for themselves than often they're given credit for. You know, this whole idea of, oh, Americans don't want to take care of themselves and they just want to take a pill. And well, I think there are some people like that, but our experience has been there are more people who are saying, I want to take care of myself. I want to know what's going on. I want to understand why I have high blood pressure or whatever. It isn't just bad luck or genes. Something else is going on. I want to be proactive on my own behalf, right? And then, of course, healthcare training has been lacking for a long time. Doctors don't get much education on nutrition and lifestyle choices. And increasingly, institutional medicine has taken over medicine to the place where the judgment of doctors is not necessarily considered. So consumers need to be well informed. And thankfully, there are a lot of healthcare providers out there who want to be better informed as well. So we have a very robust training program for health professionals. So we're going to talk about Parkinson's today, and I'm going to take a walk on the wild side technically here and see if I can successfully share my screen with you. And let's see, and it worked. Every time technology works for me, I'm pretty excited about it because I'm not very apt. I'm inept when it comes to technology. So let's just get started here with some basics. One of the most common neurological disorders is Parkinson's disease. It affects about 1 million people in the United States and about 6 million all over the world. It's less common in Asia and Africa, and I'm going to come back to that in just a little bit. But the reason that this is an important fact is when you see conditions that are what we call geographically distributed, high concentration in one part of the world, hardly any someplace else. It tells you that there's something going on besides aging, besides genetics and that sort of thing, and it's environmental. It's diet and lifestyle habits. The incidence increases with age. It's rarely diagnosed before the age of 40, but it affects about 1% of people who are older than 60. The first description of it was in 1817 in James Parkinson's publication, which was called Essay on the Shaking Palsy, and that's where the name came from. And the official definition is it's a neurodegenerative disease characterized by loss of dopamine-producing cells in the substantia nigra pars compacta of the brain. And we're not going to have a test on all these technical terms at the end, so don't worry about that stuff. And the presence of Lewy bodies and Lewy neurites, which is material and diseased neurons. And by the way, Lewy bodies are abnormal deposits of protein, and they can cause problems with movement, behavior, memory, and mood. And those are all things that are characteristically affected by people who have Parkinson's disease. Now, the most famous Parkinson's patient is Michael J. Fox, who was diagnosed in 1991 at age 29, which is very unusual. That's an outlier. He disclosed his condition, came forward and said that he had it, and then he committed himself to raising awareness and money to increase Parkinson's research, which he's done. He has a foundation, and most of the foundation's money goes to funding for drugs and drug experimentation. However, one thing I want to say about Michael J. Fox is that he has made it, he set a great example of somebody who is terribly disabled but refuses to stop living. He has had wonderful leading roles in several series on television and on Netflix and that sort of thing. So he's proven that in spite of a dire diagnosis, and this young onset Parkinson's is very, very aggressive, that he's kept himself working and he keeps himself out there. And so I wish that there was more in terms of the foundation looking at diet and lifestyle causes and outside the box thinking, which we're going to do through this presentation, but I do give him a lot of credit for what he's doing. So let's just start with some basic understandings of the pathophysiology of Parkinson's. So dopamine is produced by cells in the substantia nigra part of the brain, which is beneath the cerebral cortex. So normal function requires balance between excitatory neurotransmitters like dopamine and inhibitory neurotransmitters like GABA. And when the body has the right balance, you have coordinated movement and muscle tone and posture, and you can function like a normal human should. When dopamine production is lowered, that shifts the balance to the higher levels of inhibitory GABA, and that's where the problem starts. So some of the initial clinical symptoms are tremor, a subtle decrease in dexterity, decreasing arm swing on the first involved side. By the way, typical Parkinson's is asymmetrical when it begins. Softer voice, decreased facial expression, sleep disturbances, rapid eye movement disorder, loss of normal atonia, or stiffness, not moving during REM sleep, decreased sense of smell, symptoms of autonomic dysfunction like constipation, sweating abnormalities, sexual dysfunction, and seborrheic dermatitis. And all of those things can be signs of something else. And we're going to come back to particularly the constipation issue, which may be what we call a canary in the coal mine, an early sign that something like this could happen. A general feeling of weakness, malaise or lassitude, depression or anhedonia, inability to feel pleasure, and slowness in thinking. So all of this is a huge constellation of symptoms, and some of them are actually quite vague. Some of them are quite common. And so often the initial clinical symptoms are missed. The non-motor symptoms can be more difficult than motor symptoms. And there are various categories like autonomic functions that take place without effort, like digestion and heartbeat, cognitive, psychiatric, and sensory. And the whole constellation of non-motor symptoms includes depression, dementia, hallucinations, rapid eye movement, sleep disorder, orthostatic hypotension, pain, numbness, akathisia, which means difficulty in staying still, an urge to move that you can't control, and restless leg syndrome. And you might, looking at all of this, understand that depression is really a major feature of Parkinson's, and it has a major effect on quality of life, and it also has a major effect on the ability to help a Parkinson's patient, because when people don't believe that anything can get better, when they feel that, my gosh, I have been dug into such a hole that nothing is ever going to be better for me, that makes it worse in and of itself. So Parkinson's patients are notorious for suffering from depression. The most common non-motor symptoms at early stage would be things like excessive saliva production, memory issues, urinary urgency, reduced smell, and constipation. And again, some of these are really subtle, like how much is too much saliva production. Some of them are hard to define, like I'm 65 years old and sometimes I forget things too, but is that really a sign of something, or is it just that I have a lot of information coming in and sometimes I have to go back and look something up or whatever. But again, a person can progress for a pretty long time without being formally diagnosed. As I mentioned before, in the beginning, Parkinson's is typically asymmetric. It affects one side of the body. And the most common early symptom is a resting tremor in an upper extremity. And then over time, the person experiences what we call progressive bradykinesia, slower movements, rigidity, gait difficulty. The posture becomes progressively flexed and stiff, and walking strides become shorter, and balance impairment develops later on. The tremor occurs in about 70% of patients, but it doesn't need to be present in order to make a diagnosis. It's just really typical. So the description is shakiness or nervousness that begins in one extremity, often intermittent. And that's one of the things that makes Parkinson's difficult to spot in the beginning, is the symptoms come and go. It will often begin in a finger or thumb, but can also involve the forearm or wrist and then spread to a lower extremity or the contralateral upper extremity, but it remains asymptomatic. One side, asymmetric, I should say. One side is definitely more affected than the other. A characteristic of Parkinson's that starts early stage and then follows through is that stress, anxiety, and fatigue make all of it worse. And the most visible time when the tremor is noted is when performing activities like eating or reading or writing, because those require some fine motor skill. One thing, if you've ever spent time with a Parkinson's patient, is you will forever appreciate the ability to pick up food on a fork and put it in your mouth, and to type or write and that sort of thing. There is rest at night. Tremors generally will stop during sleep, although they maintain, they're active during the day. Bradykinesia is a term that I'm going to refer to several times, and it's defined as slowness of movement. So the patient will tell you, I feel weak. I just feel weak. I don't have any energy. Loss of dexterity, fatigue, like the ability to pick something up and hang on to it, achiness when performing repeated actions like writing or typing. Facial bradykinesia is a decreased blink rate and sort of a bland, not expressive facial expression. The speech gets softer, it can become slurred, the articulation degenerates, and the person can become difficult to understand. Truncal bradykinesia is difficulty getting up from a sitting position, walking, or even the ability to turn yourself over in bed. Kitchen gadgets and keys, I mean, anything that requires fine motor skills becomes really difficult. And then unilateral bradykinesia is the inability to lift the foot off the ground. So it's the appearance of dragging one's foot. Dystonia is described as involuntary muscle contraction. It's more common in a young onset patient such as Michael J. Fox. The foot can involuntarily turn in or down, and it's very painful. It's associated with cramping and aching in the affected limbs. Dorsiflexion of the flexion of the big toe is common, where it curls upward. Adduction of the arm and elbow is when the hand rests in front of the abdomen or chest, and it worsens again with fatigue or exertion. So to diagnose, in the beginning, it's hard to diagnose. And many times when I have dealt with Parkinson's patients and their families, they'll say, well, looking back, there seemed like a lot of strange things were happening. We just never put it together. This is what it was until it got to the place where we had to see a neurologist or a doctor. But 4 common symptoms, and 2 of the first 3, resting tremor, rigidity, and bradykinesia, are required for the diagnosis. And then the 4th one is postural instability. There are no lab markers. So, and the MRA and CT definitely do not look abnormal at early stage. So what you're trying to do is put together a symptom profile that indicates that it's Parkinson's. MRIs are often ordered, and the reason is that if you're unsure, you're not really sure what this is. And I'm going to get to the part where that doesn't really matter, because there's some things you should do anyway if you're having some of these symptoms, any of them at all. But sometimes an MRI is used just to rule stuff out. Let's make sure the person didn't have a stroke or a series of mini strokes. Let's make sure that there isn't a brain tumor or fluid in the brain or lesions associated with Wilson's disease due to copper deposition. So imaging is usually done just to make sure that it's not something, that nothing's being missed as you diagnose it. Another thing that you can do for diagnosis is look at resting tremor. The patient relaxes, is seated, puts the hands in his lap or her lap, and then is asked to count backwards from 10. And the stress of doing that can sometimes trigger the tremor. You can also put the arms outstretched, stretch outward to assess postural tremor. And the finger to nose test can test kinetic tremor, with a tremor that is associated with voluntary movement. And then rigidity, just watching the person walk and seeing this beginning of rigidity setting in. Postural instability is a major issue because imbalance is the most common cause of disability. Like the person can't walk without assistance, can't go up and down stairs, can't go out and walk on the sidewalk and just do normal functions associated with life. One of the ways that you can assess this is have the patient stand with eyes open, pull their shoulders back, And what will happen is they'll lose their balance, and they sometimes have to take a couple steps backward to regain their balance. And so the patient can fall, which is why the person measuring this will often stand in back to catch the person if that were to take place. Laryngeal dysfunction and dysphagia. This is defined as a soft monotone voice, vocal tremor, poor articulation, varying speech rate. If the person is told to, listen, we can't hear you, can you speak louder? It usually results in improvement at the time, at the beginning, but that goes away. And then dysphagia is impaired verbal communication. And by the way, that's what happened to Bruce Willis. Some of you might have read about that. He's developed dysphagia, so he cannot act and appear in films anymore. And then drooling or aspiration. Autonomic dysfunction is orthostatic hypotension. That appears toward later stages. Impaired intestinal motility. So we're talking about constipation as the primary thing here. And again, I'm going to come back to this a couple more times. It's often the Canary and the Coalmine. Vomiting and impaired nutrient absorption. Urinary symptoms include retention, urgency, frequent bladder infections, erectile dysfunction, and then random episodes of sweating for no reason at all. Dementia is common. The prevalence is 20 to 40%. There is a between 2- and 6-fold increased risk for Parkinson's disease patients to develop dementia as compared to controls. And the variability, by the way, is based on different studies showing different things, but they are at higher risk. But even an early stage patient can begin to suffer. It's a perceptible loss of executive function. The most common time of onset for cognitive impairment and dementia, meaning that the person literally can't be left alone and function on their own, is 8 or more years after the motor symptoms appear. And then this is when the depression becomes severe as well. And when you just think about it, losing independence, anybody who loses any measure of independence goes through a period of depression. And so it's not surprising that that happens with PD patients. Atypical Parkinson's bears mentioning. It's neurodegenerative disorders with Parkinsonian features, and the prognosis is actually worse than Parkinson's. The patients do not respond well to treatment. That's how you figure out that it's atypical Parkinson's. And this includes things like, I'll save all the fancy terms here and just get to the English translation, like the inability to look in a particular direction, abnormal and involuntary movements, and cognitive dysfunction. And then loss of nerve cells and shrinkage of several parts of the brain, which you can see in imaging, diffuse Lewy body disease, cognitive dysfunction within 1 year of onset. By the way, that was one of the things that Robin Williams was suffering from at the time that he killed himself. The clinical features are falling at early stage, symmetry. This is the asymmetry, as I mentioned before, is a characteristic of Parkinson's disease, and atypical Parkinson's is equal both sides. Poor response to the drug levodopa, which we'll talk about in a couple minutes here, rapid progression and no tremor. So there are people who have symptoms of Parkinson's, but they're not diagnosed with Parkinson's and they don't respond to treatment. Now, here's where we get to the really interesting part. I started doing research on Parkinson's disease when the first person contacted me many, many years ago, asking for help. And so I knew what it was. I mean, I studied this in school. I knew that the prognosis was pretty awful. The only thing that I ever learned about really was that these people take drugs until they don't work anymore. And then Parkinson's patients live out their life in some type of care home, usually, because it becomes almost impossible to take care of them at a certain point in time. And it's not unlike an Alzheimer's patient where the family has just an incredible burden to take care of the person, and it becomes unbearable after a period of time. So I wanted to look at this from an alternative point of view. I always assume that there's something out there that hasn't been discovered yet, and if we research enough, we can find it. So what I found, and I'm going to share with you on these next few slides, is that Parkinson's disease, we don't know if it's an autoimmune disease, but it shares a lot of features with autoimmune disease. And why that becomes really important is that we know a lot about how to help autoimmune patients who, with diet and lifestyle choices and water fasting. I mean, I've done lectures at this conference on autoimmune disease, and I think that it's a lot of work to do all the things that you need to do to maintain function and keep autoimmune diseases from progressing. But it's worth doing because it limits the disability factor. Well, if Parkinson's disease actually is an autoimmune disease, or we even suspect that it is, this opens up a whole lot of treatment options that I'll share with you. All right, so the first thing is inflammation. High levels of inflammation are present in PD patients in the periphery and in the brain. Autoreactive, and that's a feature of autoimmunity, T lymphocytes, autoantigens, and microglial activation are present. And so inflammation and autoimmunity may be important contributing causes. And I actually found quite a bit of research that talks about this. So it's known for 30 years that inflammation is present in the brains of Parkinson's patients. Now it's considered a likely contributing cause and related to the progression. So Rosette and his research team looked at patients with and without Parkinson's, and the patients who had been prescribed 2 classes of immunosuppressant drugs had a lower risk of developing Parkinson's disease. And the 2 of them were corticosteroids and inosine monophosphate dehydrogenase inhibitors. That's a mouthful, right? Well, the important thing is that these are 2 classes of drugs that are used to treat autoimmune patients. And patients who had been prescribed either or both of these classes of drugs had a lower risk. So that doesn't mean that Parkinson's is an autoimmune disease, but what we try to do is say, okay, let's just look at all the things that possibly point in that direction. Let's see how they stack up. So just keep that in mind. All right, here's another thing. Fats damage the blood-brain barrier. Now, not all fat, and I mean, in other words, you need some dietary fat, but we live in a society right now in westernized countries where people are almost on a ketogenic diet just by virtue of the fat that's in their daily diet. So if you consume too much fat, you have the potential to damage the blood-brain barrier. And this is one of the mechanisms of action that can lead to multiple sclerosis. This allows antibodies to enter the cerebrospinal fluid and attack brain cells. We refer to it as molecular mimicry, and I'm going to come back to that and explain it a little more in depth. Molecular mimicry, by the way, is a factor in many autoimmune diseases. So the amino acids in dairy that make up the proteins in dairy have been shown to contribute to autoimmune diseases like juvenile diabetes. And the way that this works is that when you have a broken blood-brain barrier, a broken gastrointestinal leaky gut, you end up with antigens crossing these barriers, and in the gut, undigested dairy proteins, for example, the amino acid chains that make up those dairy proteins look like the amino acid chains that make up the beta cells in the pancreas that produce insulin. And so the antibodies that go after those dairy proteins can go after those beta cells. The same thing is true with the amino acid chains and gluten, which are related to thyroid autoimmune disease like Hashimoto's or Graves' disease. So the idea that protein fragments could be related to Parkinson's disease is not a crazy idea at all. We know that molecular mimicry is a factor in many autoimmune diseases. In fact, one group concluded autoimmunity is actively involved in the pathogenesis of Parkinson's disease through several proteins, and they list them here. And then furthermore, a detailed analysis of the relevance of autoimmunity to the clinical symptoms of PD provides strong evidence for the close correlation of autoimmunity with PD. So again, this isn't proof positive, but there's more out there. There's more research teams looking at this than you might imagine. And I've never met, by the way, a Parkinson's patient who has ever consulted with a doctor of any type, including naturopaths, who has suggested, you know what, maybe we should look at this as an autoimmune disease because it opens up a whole plethora of things that we might be able to do to help you that might not be thought of otherwise. So for a long time, autoimmune disease was ruled out due to the assumption that brain cells were protected from immune system attack. I mean, autoimmunity means that the immune system cannot any longer differentiate self, as in your body, from non-self, as in foreign agents coming into the body, like undigested food fragments or bacteria or viruses. But the reason this was thought to be the case, that autoimmune could not be associated with PD, or PD could not be an autoimmune disease, is that it was thought that most neurons don't have antigens or markers used by immune cells to identify a target. But in 2017, a research group at Columbia University did discover that there are antigens on neurons that produce the neurons that produce dopamine. This was discovered in postmortem tissue samples. And this team has conducted blood tests which show that people with Parkinson's disease mount immune response to these antigens. People without Parkinson's disease don't. And that may go to a couple of reasons why this affects some people and not others. One is genetic predisposition, which, by the way, is a very minor part of this, but it bears mentioning. And the other may be other comorbidities. In other words, we'll talk about some of the risk factors for autoimmune / PD. And you'll see that a lot of people in the United States and in westernized countries have a lot of risk factors for autoimmune and Parkinson's disease by virtue of their diet and lifestyle habits. I've mentioned this a couple of times, that constipation is associated with a higher risk of Parkinson's disease, and it often precedes it by as much as 10 years. Now, we live in a constipated society. I haven't watched television for a couple of years, but I remember back in the day when I used to watch the news. I don't think I ever watched a news program where there wasn't at least one commercial for a laxative, right? So there is a correlation between worsening constipation and the progression of Parkinson's disease. Now, I mentioned this before about leaky gut. Constipation can result in leaky gut, where the microbiome and the tight junctions that allow for a solvent drag to take nutrients into the bloodstream and also provide a barrier system to keep things out of the bloodstream becomes compromised. So constipation is a factor in that, and it's a major contributing factor to autoimmune, which is again a common denominator with Parkinson's disease. The mucosal and fecal microbiota are different in Parkinson's patients than controls. There are less bacteria that produce anti-inflammatory substances like butyrate, more pathogenic bacteria. And this could trigger inflammation-induced misfolding of a neuronal protein in the development of Parkinson's disease. So a consistent characteristic of Parkinson's disease is intestinal permeability. A consistent characteristic in AID is intestinal permeability as well. Another thing that's interesting, that there's such a relationship between the gut and autoimmune and the gut and PD. Specific bacterial profiles are associated with PD and severity of symptoms. In other words, you can look at the microbiome of a Parkinson's patient and you will see a very specific fingerprint. It's a good way to look at it in the microbiome. And there's significant sensitivity for matching a fingerprint in the microbiome and Parkinson's disease. There are levels of 4 bacterial families, and the severity of constipation, we're able to identify Parkinson's patients with 66.7% sensitivity and 90.3% specificity, the fingerprint of the microbiome and the severity of constipation. So again, it looks more and more like an autoimmune disease. And again, the only reason why we might want to term it that is that it opens up treatment options. When germ-free mice were implanted with microbiomes from Parkinson's patients, motor function worsened, another clue that the microbiome is involved. Some studies show that this protein deposition begins in the gut and travels throughout the body via the vagus nerve and the central nervous system due to a breach in the blood-brain barrier, again, a characteristic feature of particularly multiple sclerosis and autoimmune disease. ASIN has been found, this protein has been found in the nerve fibers of the colon in early stage untreated Parkinson's patients, but it's not present in healthy controls. Intestinal inflammation is common in PD patients with increased levels of pro-inflammatory cytokines. These inflammatory markers are correlated with disease progression. Remember, inflammation is a factor in every disease. And by the way, one of the biggest contributing factors to inflammation in westernized countries is being overweight or obese, because your fat cells actually pump out inflammatory cytokines. So the reason why you want to pay attention to weight as a means of preventing disease as much as anything else. Constipated PD patients have higher levels of inflammatory markers than PD patients without constipation. So it seems that a history of constipation and constipation throughout the course of the disease are major factors for how severe and how fast the disease progresses. Now, this is really interesting. Inflammatory bowel disease is an autoimmune disease, and the terms you're used to hearing are Crohn's disease and ulcerative colitis, the two major categories. IBD patients have a higher risk of developing Parkinson's disease than people without IBD. Now, one of the hallmark features of autoimmune diseases is if you have one, you're likely to develop more of them if you don't do something to stop the progression of the first disease and address the causes, right? So the idea that an IBD patient has a higher risk of developing Parkinson's, again, it's just building that base of information that tells us maybe this really is autoimmune. So it's an important area of research. It's not medically confirmed. And I didn't show you all of my slides. I mean, I have a whole course on Parkinson's disease. So we would have been here till morning if we went through the next morning, if we went through all that stuff. So I tried to just highlight some of this. But the importance of this from my perspective is we know a lot more about autoimmune and how to treat it than we do Parkinson's. And we know that diet and lifestyle change can be very effective for slowing or stopping the progression of AID and reducing the risk that you will develop a second autoimmune diseases, or in some cases, we've even seen autoimmune conditions go away, particularly if the intervention is early enough. And there is no risk associated with treating Parkinson's patients with the same diet and lifestyle protocols as AID. I mean, the things that I recommend to people, and those range from diet change, exercise, et cetera, and also how to have better and more constructive conversations with your doctor, because that's always a good idea. But nobody gets worse from eating more vegetables. Nobody gets worse from taking off 50 extra pounds. People do not get worse when they start exercising. They don't get worse when they drink more water and they sleep better and that sort of thing. So there's nothing to be lost by taking this approach to Parkinson's. A couple of other things that I'll cover, and this slide involves something that I try to stress to everybody. Compromised blood vessels and reduced blood flow to the brain due to coronary artery disease can cause the death of brain cells and tissues. And what causes that? One of the big causes is a diet that is really rich in animal foods and fat. Too much protein, too much fat, too much animal food. We've always recommended that people dial that back a lot. And then high iron intake is linked to both Parkinson's disease and compromised blood vessels, atherosclerosis. The most absorbable form of iron is heme iron, which is found in meat. And so I said before, this is a point that I like to make, is that diet has such a breadth of effect. Eat a bad diet, and there is no limit to the number of bad things that can happen to you. I mean, I hate to sound like a doomsday girl, but it's true. Change your diet, and it's astounding the number of different diseases you can prevent and the positive effect that you can have on almost any of the diseases that you have. There are obviously exceptions to the rule, but the rule pretty much is if you've got the misbehavior, if you want to call it that, I don't want to sound like a school marm here, but misbehavior in the diet and lifestyle areas will lead to sooner or later something going wrong. And the question is, how serious is it going to be, and how many things going wrong are you going to let happen, right? So some of the causes, genetics definitely plays a role, but as I said, a minor role. And by the way, just one thing that I don't think we talk about enough is that everybody got very excited when the genome was mapped, and people started looking at all of these different genetic mutations, hoping to find specific markers that would tell you what was going to happen to people. You're going to develop this disease or not develop this disease. And it was astounding how low the correlation was. And it doesn't mean that it's non-existent. It just means that you pretty much can overcome genetic predisposition. It works both ways, by the way, not just for Parkinson's, but for other conditions. In other words, you could have a terrible genetic profile. I actually do, by the way. I come from a family of women in my family who have had autoimmune disease for generations. Okay, so terrible genetic profile, but I've overcome it by taking care of myself. You can have a great genetic profile and you can overcome that by not taking care of yourself. So it works both ways. Environmental toxins actually plays a pretty minor role unless you consider the environmental toxins that are in conventionally grown animal foods in our society. Prions, this is closely related to it, abnormal folding of proteins, which can cause brain and neurological damage. They can be acquired or due to genetic predisposition. Acquired is mad cow disease, which I'm sure you've heard of, passed from cows to humans through contaminated food. The human form of the disease is called variant Creutzfeldt-Jakob disease. It's considered rare, but sometimes I wonder how rare it really is when I see so many conditions with neurological disorders that would be characteristic of it. I wonder what the level or the incidence of misdiagnosis is. Oxidative stress, which most people experience a lot of based on their daily habits. Neurotransmitter imbalance, mitochondrial dysfunction, which can be due to a high-fat diet and inflammation. That also leads to diabetes, by the way, type 2 diabetes. Age-related decreased production of dopamine-producing cells. And the fact that it's age-related doesn't mean that it has to happen to you. In other words, we have this picture of aging in our culture that I think is so sad, where you reach a certain point and then you just degenerate for decades. And I have just not signed up for that program. I don't want to be part of that program. I intend to live until I die. And I get very inspired when I read these stories of people living to be 100, 105, 110 years old. And just one thing I want to point out to you about these people, and you can go online and read all day long these centenarians and their stories. There's a lot of very inspirational, but I have never read one that said, the reason I live to be 105 and why I'm still doing street races, I've covered this in one of my videos, by the way. A woman was entering street races when she was over 100 years old. They had to create a new age category for her. All right, so anyway, the reason why I've lived to this ripe old age is thank God for the doctors in my life. I really was diligent about doctor visits and making sure I hung out with lots of doctors all the time, and I owe my great health to them. Not one of them has ever said that. It's their diet, it's exercise, it's staying socially active, all that sort of thing. So this whole business of falling apart as you age, it just felt like I needed to make those comments here. Inflammation, increased rate of cell death, abnormal response to dopamine in the brain, and a high intake of iron, which I mentioned before, but bears mentioning again, and it's coming from animal food. Medications like tranquilizers and drugs used to treat gastroparesis or slow-moving digestive system in diabetics can cause Parkinson's-like syndrome symptoms. And I mentioned before, constipation can be the canary in the coal mine. Constipation is the canary in the coal mine, not necessarily specific to Parkinson's, but specific to everything else you don't want to have happen. It increases your risk of colon cancer. It increases your risk of everything, including damage to the microbiome, which is really sort of the thermostat for your immune system. So taking care of your gastrointestinal tract is a key to maintaining health, protecting yourself against all conditions. Exposure to pesticides may be a factor in genetically susceptible people. Some people do not detoxify things very well. And concentrations of deldrin, which is an insecticide, compounds in the substantia nigra are higher in PD patients. But even that is somewhat controllable by keeping your body in good shape. We have an amazing capacity to detoxify all kinds of things if we're doing everything right. Most of the chemical intake actually is from food: meat, chicken, eggs, fish, and dairy. Dairy is a special category, which I'm going to cover. I have a couple slides about dairy specifically. If you are going to eat animal foods, and I've never drawn that line in the sand that says that if you eat any, you're not going to be able to be healthy, because I don't think it's true. I don't consume them, for the record, but if you're going to choose to eat animal food, eating a small amount, and I'll show you what that looks like in a minute, make sure it's organic or wild caught, because if you really do some research on the way that conventionally grown animals and fish, farm fish are grown, you would never consume this stuff. It's absolutely gross. The highest incidence of Parkinson's disease is in Europe and North America. And as I said at the very beginning, Rural Africans, Chinese, and Japanese you don't see any Parkinson's disease in Okinawa. And in these places, there is a much greater focus on plant-based eating. Milk consumption. I said dairy was a special category here. It usually is in most disease processes, actually. But milk consumption in middle age is associated with a higher risk of Parkinson's disease. Men who consume more than 2 glasses of milk a day or the equivalent have 2 times the incidence of Parkinson's disease as men who do not consume cow's milk. And by the way, added incentive, if you're a guy, not only do you not want to get Parkinson's disease, but there is a huge connection between, well proven, between consuming dairy products and prostate cancer as well. The highest consumers of milk have twice the risk of Parkinson's. 4 prospective studies have shown an association between eating dairy products and a higher risk of developing PDs, particularly in men. The increased risk for people eating dairy ranges from a low of 10% to as much as 230% in some studies. And the greatest risk is that category of people who consume 16 ounces of dairy or more per day versus those who consume no dairy. And again, there may be some molecular mimicry involved because dairy is a huge trigger based on molecular mimicry for type 1 diabetes. According to a meta-analysis of studies, dairy intake resulted in a 60% increased risk of developing PD in men and women combined, 80% greater risk in men, 30% higher risk in women consuming the most dairy compared with those who consume the least. And one of the reasons why this is important is that when you see a dose-dependent effect, like the incidence of Parkinson's in this case increasing as dairy increases, the dose-dependent effect is some added information it gives you more justification in saying there's likely a connection. I mentioned weight. Weight is a factor for everything, a risk factor for everything. Overweight in midlife is identified as a risk factor. People with a BMI of 30, twice the risk of PD versus those with a BMI of less than 23.5. And inflammation is the risk. That's why you see such a connection between obesity and overweight and all diseases, including cancer, is that your fat cells are very busy pumping out inflammatory cytokines and inflammatory chemicals that raise inflammation levels in general and put you at risk of many, many things. And by the way, that's where genetics comes in. You know, if you take a look, and let's say we line up 20 people and we have them eat the same terrible diet starting at the same age. Sooner or later, something will go wrong with these people. The age of onset will have something to do with genetics. And also the flavor of disease. So one person does all the wrong things and ends up with cancer, another one has a heart attack, somebody else becomes diabetic, somebody else develops an autoimmune disease. It's all related to the habits and the weight that results from those habits. So let's talk about traditional treatment and what it yields. Levodopa combined with carbidopa are the gold standard. Carbidopa inhibits the decarboxylation, which prevents the levodopa from being broken down before it reaches the brain. So it's an escort service, if you will. Levodopa has positive effect on motor symptoms with the fewest side effects in the short term. But in the long term, like with so many conditions, sooner or later, it doesn't work so well anymore, and dyskinesia results. There are a lot of side effects of the carbidopa: dizziness, drowsiness, blurred vision, nausea, vomiting, dry mouth, loss of appetite, heartburn, diarrhea, constipation, sneezing, stuffy nose, cough, muscle weakness, muscle numbness and tingling, sleep issues, skin rashes, itching, and headache. Other than that, it's great stuff. But the reason why it's important to focus on this is that in early stage, it is not a bad idea to see if you can stop the progression of this with diet and lifestyle change, treating it as if it's an autoimmune disease, because these drugs are always there and available to treat Parkinson's disease, but maybe not the best first thing to start with. MAO inhibitors, monoamine oxidase breaks down dopamine in the brain, so inhibiting it preserves dopamine. It's used for early stage treatment. A Cochrane review, before Cochrane went to the dark side and started taking money from places it shouldn't. Long story there that we'll save for a different day, but The Cochrane review, which at one time was the gold standard, said that it really did make a difference. There are side effects: dizziness, drowsiness, insomnia, nausea. And the side effects with long-term use become difficult to tolerate, and I have them listed here. So, it's also not a plan for a long period of time. Dopamine agonists bind to and activate dopamine receptors, which can delay the start of the drug. In other words, a conventional medical approach is to see if you can delay the start of the drug. So what I'm saying is, if you're going to do that, instead of delaying the start of levodopa and carbidopa, why don't we, with other drugs, why don't we delay the start of any drug by doing the right things and see if we can slow it down? And we've had several instances in which we were able to do that. This strategy can delay the development of dyskinesia, works better in younger patients, but there are adverse events. There are always side effects to drugs. The side effect to the diet is you get better energy and you might delay the onset of disease or reverse it even. But the side effects to drugs are serious, and these are serious: hallucinations, impulse control issues, etc. The best is to use these drugs for patients who have less cognitive damage. I'm not fond of them at all, to be truthful. Anticholinergic agents are not used as first-line drugs because of limited efficacy, and they also have neuropsychiatric effects. They provide relief from tremor in half of patients, but they don't improve other symptoms much at all. And adverse cognitive effects are most common in older patients, and cognitive problems are a symptom of Parkinson's as it progresses. And by the way, one of the reasons to pay attention to that as you're thinking about, are we going to take drugs and which ones, and that sort of thing, is that one of the leading problems, in addition to the physical disability that makes it almost impossible for Parkinson's patients to stay at home, is if they become cognitively dysfunctional enough that you can't leave them alone at all. That's how Alzheimer's patients end up in nursing and care homes and memory homes and that sort of thing, because the family just can't provide 24/7 surveillance, so that the person has to be put someplace else. In terms of what you can look at if drug treatment is the way that this is approached, is control of motor symptoms with drugs will last 4 to 6 years, after which the disease progression accelerates and eventually disability ends up resulting. The younger patients, worse prognosis. If you're going to get this disease, you want to get it when you're older, not younger. You're much more likely to develop motor impairment and dyskinesia and have to live with these types of restrictions for a longer period of time, longer period of disability when you can't really participate in life the way that you want to. Within several months to several years after beginning levodopa, patients develop what's called peak dose dyskinesia, twisting and turning movements, which occur when the levodopa-induced dopamine levels are peaking. Decreased medication can worsen Parkinson motor symptoms. Some patients prefer some dyskinesia to a lower drug dose. The bottom line is, by the time you get to this point, there aren't any good options. They're all bad in some way. So you're picking the best of the bad options. And the goal would be to try to avoid that. There are some interventions that are helpful. One is deep brain stimulation, which is implanting of a battery device that provides electrical stimulation to the brain. It can be effective even for people with advanced Parkinson's. It reduces tremor, rigidity, akinesia, and postural instability, and results in lower doses of levodopa, which means that the period of time during which levodopa could be used would be extended. The adverse events are mainly neurocognitive. The result is that you affect surrounding areas of the brain. So it's a difficult decision to make whether or not it's a good idea. Pallidotomy is a surgical procedure that destroys the globus pallidus, which regulates movement. It's overactive in Parkinson's. It does result in significant improvement in some areas, but the risks include cerebral hemorrhage and death. And so it's very important that the patient, a lot of consideration to the risk-benefit ratio. And some, I think, younger patients benefit a whole lot more than older patients. And due to the long period of disability that the person's expected to have, the risk is probably much more worth taking than it would be in an older patient. Thalamotomy is surgical destruction of the part of the thalamus, and it's used for the treatment of incapacitating tremor and rigidity. It's very, very painful. The ideal patient is younger than age 65, has cognition intact, still ambulatory, and doesn't have serious cardiovascular disease, which would be another reason for a Parkinson's patient to change diet. Not only might you be able to avoid all of this stuff, but if you actually did progress to the place where you needed certain types of treatment, you'd be better able to withstand them if you were, if your cardiovascular system was in good shape, for example, here. About 3/4 of patients show some improvement. About over half of them, it's significant. It doesn't improve some things, including mental changes. And that, again, is the biggest thing that contributes to burden of these patients on their families. All right, you won't be surprised to hear about this coming from me. A plant-based diet can reduce the risk of Parkinson's disease. In other words, the best thing is to not get this disease in the first place. Many people who come from families where there have been 2 or 3 cases of Parkinson's can avoid it. Your best chance of avoiding it is taking good care of yourself. Diets high in animal fat or cholesterol are associated with a significantly higher risk for PD. Fats from plants do not increase risk significantly. However, that blood-brain barrier that I talked about, that's so important, too much plant fat will cause damage to the blood-brain barrier. The prevalence of Parkinson's disease in places where people eat a much more plant-based diet, we're talking about sub-Saharan, Black Africans, rural Chinese, Japanese, incidence is considerably lower, which tells us that it's not genetics, it's not age, it really is lifestyle. Here are some studies showing that, a diet more plant-centered, but even including some fish, can reduce the risk of Parkinson's disease. High intake of fruits, vegetables, fish, legumes, nut, and soy were associated with 25 to 30% lower risk. A case control study in Japan, almost 50% lower risk for Parkinson's disease and people eating a diet high in vegetables, seaweed, legumes, mushrooms, fruit, and fish compared to those that were eating the lowest amount. So when your mother harped on you all throughout your childhood to eat your vegetables, do that, all right? And your legumes and mushrooms and fruit and other plant foods. Again, I've never tried to, I'm a fairly well-known vegan. I like eating a vegan diet. I've never tried to get everybody to do it, first of all, because I can't scientifically support it. But the other thing is that it just isn't, it's easier to get people to convert to a diet that still includes some of this stuff and get them to stick with it. So I'll come back to that a little bit too. And here we are, once again, looking at the dairy issue. Consumption of dairy products and drinking milk can increase the risk of PD. And the risk is independent of calcium intake. It is not calcium that's driving this problem. Brain tissue doesn't regenerate, at least as far as we know. You can do some remapping. That's a different workshop. Maybe I'll do this next year on how you can remap the brain. There's a great psychiatrist in California. He's published a lot of research in this area. But for the most part, brain tissue doesn't regenerate. So the sooner dietary intervention starts, the better the outcomes are. And so we have had, the best effect we've had here is working with somebody who has a family member who has been diagnosed with Parkinson's. It's early stage. The person is still somewhat self-sufficient, able to do a lot on their own, and supportive family. And at that stage, it's often the case that we can really draw out the progression or stop it from progressing. But when we get patients who are well down the path of disability, there is a point of no return. And so we prefer for people to do something right away. The high carb diet is best. Carbohydrate increases dopamine production, through by allowing tyrosine, which is a precursor to dopamine, to pass more easily across the blood-brain barrier and into the cerebrospinal fluid. So the high carbohydrate diet is best, not high protein and not high fat. Animal foods actually have concentrated amounts of amino acids that block the passage of tyrosine. And your plant bases of this particular amino acid are peanuts, almonds, avocados, bananas, lima beans, pumpkin seeds, and sesame seeds. Now, this is just a case report. It reflects one person, but a 75-year-old man with Parkinson's for 8 years had changed to a semi-vegetarian diet for a couple of years, no progression, no increased meds, and improved quality of life. So slowing the progression, you win. Stopping the progression, you win, even if you can't reverse it and go back to normal. And I have not seen that necessarily, but if you can keep it from getting worse, increasingly in so many areas of our business, we're trying to talk to people about dying with diseases and not from them, all right, and maintaining independence and having a high quality of life. Levodopa is taken orally. It crosses the blood-brain barrier. Amino acids from protein use the same carriers, and so they compete for transport. So in this way, a high protein diet can cause you to need increasing amounts of levodopa earlier, higher doses. So if you restrict dietary protein, you may increase the effectiveness of the medication. Lower doses might be needed. Maybe none would be needed in some cases. Patients are sometimes, there's an awareness of this because patients are often told to restrict protein during the day and eat it at night in order to avoid interference with medications. There's no reason to increase protein consumption at any time. This is a discussion that goes way beyond this lecture. We'll be here all night, but it's impossible to not eat enough protein if you're getting enough calories every day. Patients were randomized to eat a plant-based diet or omnivorous diet. Significant reduction in Unified Parkinson's Disease Rating Scale, subscore 3, motor performance, and the modified Hain and Yahr staging scale for plant eaters. These data suggest that plant-based diet might be useful in the management of Parkinson's patients by improving their motor performance. All right, so this is not an idea without merit at all. Ketogenic diets have been shown to improve symptoms and outcomes, but this evidence is limited to case reports, and this may be because of the low protein intake. In other words, ketogenic diets are high fat, also low protein, low carb. And there's been a lot of discussion in several areas of diet. One is this intermittent fasting fad. Is it the fact that protein is limited, or is it the eating window? When people eat a ultra low calorie diet, is it the low calorie or is it the protein limitation here? Is it really that the person is in a fasting state to be in ketosis, or is it the low protein intake? One word of caution: I have seen so many people over the years who claim to be eating a ketogenic diet because they're eating a high fat diet. If you are actually going to use a ketogenic diet for treatment, it is imperative that you measure everything you eat and you check your ketones several times throughout the day, particularly in the beginning. So just one example I'll mention to you is a couple of examples where patients with cancer have thought that they were eating a ketogenic diet. Nobody ever told them about the need for it to be so specifically structured. And the cancer progressed because they weren't actually in a state of ketosis. And so it's a big decision to eat a ketogenic diet. It's hard to sustain, and you need to be constantly diligent and vigilant about it. And a lot of people think they're eating a ketogenic diet who really aren't. And I think, based on what I've seen with the Parkinson's patients, that the effect, to the extent that it works, it's protein restriction. And there is another way to get there. Just eat a lower protein diet, okay? And it's easy enough to do on a plant-based diet. So this is our food guide pyramid it's our autoimmune, with an autoimmune edition, right? So some of you have seen this before, and you'll notice at the bottom, 64 ounces of filtered water, maybe more, depends on the person, physical activity and sweating and that sort of thing. I'm a hot yoga fan, so 90 minutes in the hot room, you lose a lot of water, so more water is needed. Legumes, whole grains, you'll notice no brow foods under the whole grains category: barley, rye, oats, and wheat. And it's due to molecular mimicry. And that's a topic that goes beyond how much time we can spend here. But we cut out those foods. And then potatoes, squashes, and corns. Your calorie density comes from these starchy foods right here. Lots of vegetables, lots of fruit, minimally processed grains and cereals and breads and tofu, minimally processed foods. Notice no brown foods here. Higher fat plant foods, we minimize those in the diet. Organic animal foods, 2 to 3 times a week, optional. Don't have to eat them, they're optional. But one of the reasons we've always included them in the diet is, first of all, we can't really find any scientific evidence that says that continuing to include them is a problem, but it's a dose dependent effect. So if you look at these healthy populations, they're eating a very tiny amount of animal food, which we, you know, arrange in our diet 2 to 3 times a week because it's more suited toward the way that people in our society eat, as opposed to using animal food to season dishes that serve lots of people and etc. But not required. Okay to give it up too. And then you'll see at the top treats, occasional. And this is where it's okay to have birthday cake on your birthday and a glass of wine on New Year's Eve or something of that nature, but the operant term here is occasional. And we found over 27 years of doing this that if you have a strong personality like mine, you can get people to commit to never eat another cookie and never have another alcoholic beverage and that sort of thing. But in the final analysis, the likelihood that a young person is actually going to follow through on that is about 0. So let's just build it in and do occasional. And sometimes people will get cute with me and say, well, you know, you say holidays and birthdays. What about National Kidney Donor Week? Well, we don't have to get ridiculous about it, right? But, you know, birthdays, when friends are visiting from Australia, that kind of thing. Most of the time, you know, this lecture is taking place on a Monday. I think every day is great. I want to have the best time possible, but it's just Monday. So I'm just eating my plant-based food as reflected in this eating plan here today. All right. So beyond diet, we have always used probiotics with autoimmune patients. And so we recommend them for Parkinson's patients too. Probiotics have been shown to actually help. We have some research showing that it makes things better for Parkinson's patients, restoring the microbiome, which stands to reason. If a hallmark, if there's a microbiome fingerprint that's associated with Parkinson's disease, that much more pathogenic bacteria and not so many good guys in the microbiome, it would stand to reason that reversing that should be helpful. And by the way, you have to do it with probiotics. In other words, your body doesn't make these bacteria. Fermented foods do not contain them. Fermented foods can be part of feeding a healthy microbiome, but you could never eat them and it would be okay as well, just for the record. So you have to actually take the bacteria. And so we always recommend that Parkinson's patients take them. It's shocking, but to some people, but caffeine can actually be protective. There are some studies that show that. Caffeine enhances dopamine signaling in the brain. So I don't think that our Parkinson's patients should take up caffeinated beverages as part of their treatment plan, but I don't think we should spend a lot of time talking them out of it either. And just for the record, that holds true for other things. One of my colleagues wrote a very long, like 24-page referenced article on coffee, and showed that you know, you don't want to take up the habit if you don't like it, but it's beneficial enough, more benefit than harm shown, and beneficial enough that you don't want to spend a lot of time talking people out of drinking coffee either. 61 people with Parkinson's took either a placebo pill twice a day or 100 milligram caffeine pill twice a day for 3 weeks, and then they increased it. Results at 6 weeks, the caffeine group averaged a 5-point improvement on a rating scale of Parkinson's symptom severity, averaged a 3-point improvement in the speed of their movements and the amount of stiffness they experienced compared to those who took placebo. Again, I don't think I'd recommend coffee drinking to people who don't like it, but no reason to restrict it to people who don't. And you can also get caffeine from green and black and oolong tea as well. Now, here are some of the challenges in taking care of a Parkinson's patient that you need to be aware of if you have a family member who has Parkinson's or if you're in the healthcare business yourself. Inability to eat enough. Eating is a lot of work. And so the texture of foods can be really important, and smoothies and things that blended foods can be helpful. And blended foods can help to increase caloric intake without increasing the volume of food. You can add avocado and tofu and just blend it all together. Difficulty chewing, again, an argument for our blended foods. Difficulty swallowing, an argument for blended foods. And sometimes for advanced patients, they do have to be tube fed. Inability to shop and prepare food. When we get people early stage, they can be much bigger participants in their life without so much help from family and friends. But when we get advanced patients, to the extent that you still want to stop the progression if you can, particularly if the person is mentally sound and could actually live independently or outside of a care home would be a better term for it, for the rest of their lives, they would have to have help. And family, community, and church are where the help comes from. And I can't tell you how many people I've recommended join a church to get some community support, not just for this, but for many other things as well. And social interaction is so important to the welfare, the well-being is a better way to put it, of humans, that for many people, it's a place to meet people for social support. Inadequate water intake. Parkinson's patients sometimes don't keep track of it very well. It's difficult to drink water if you've got tremor. And then drug nutrient interactions, specifically protein. And of course, the thing that we're always up against when we talk about these things is the neurologist or the doctor who's treating the Parkinson's patient saying, oh, diet doesn't have anything to do with it. Whoever told you this crazy idea about it's kind of like autoimmune, and probiotics are good if you take an antibiotic, but they have nothing to do with it here. So we constantly have to listen to that chorus. But if the family is on board and has seen some of this evidence, they can make a huge difference. Gastrointestinal challenges, changes in muscle function can lead to gastroparesis, actually this very slow transit of food through the system. Small, frequent, lower fat meals are helpful. I mean, the problem with fat is fat slows the transit of food through the body. It's a bad idea for anybody. It's a bad idea for me, and there's nothing the matter with me. I'm in perfect health, right? But it's a very bad idea for the Parkinson's patient because they tend to suffer from constipation anyway. So small, frequent, low-fat meals are helpful. Enteral feeding is sometimes required. They often experience reflux, early satiety. It doesn't take much to make them feel full. Their appetite shrinks a lot, nausea and vomiting. You might have to restrict things like red and black pepper, fat, coffee, and alcohol. And I said coffee could be beneficial, but if it causes reflux, it's not. Candied ginger or peppermint are good for nausea. And even peppermint essential oil rubbed onto the upper lip, the scent of it, if the person still has a strong sense of smell, can be very helpful. By the way, the early satiety comes from constipation and gastroparesis. In other words, food not moving through the system quickly. Some of you who've been eating a plant-based diet for a long time, like I have been, probably noticed that when you're eating a low-fat plant-based diet, you have to eat more frequently because the fiber moves everything through the system quickly. So every 3 to 4 hours, you need more food. Well, the constipated patient with Parkinson's disease who also is suffering from gastroparesis, it takes a lifetime. I mean, it just seems like an eternity for things to move through the system. The medications that are prescribed throughout the course of the disease can cause nausea, anorexia, and vomiting, make the person just not want to eat. And then you get into the cycle of not eating, no energy, feel like crap. The person becomes increasingly difficult to motivate to do better for themselves because they just feel terrible all the time. One thing that does make a difference is exercise. It improves symptoms and outcomes. Group exercise is helpful because it reduces depression. Being around people is therapy. It is some of the best therapy around. Land-based and land-based plus water-based exercise programs are helpful. It can improve the gait for the Parkinson's patient. Tai Chi is a traditional Chinese martial art. Probably have heard of it. It combines deep breathing and relaxation with slow movements that maintain postures. It's been shown to improve balance, posture, and strength. 195 subjects with Parkinson's were randomized to Tai Chi or just a regular resistance training and general exercise. All groups showed improvement in motor function at the end of the 6-month period, but the Tai Chi group was actually statistically better in terms of postural stability and fewer falls. And that's another thing, in addition to the cognitive decline that can land a person in a facility, is that their inability to be stable enough to even walk around, to do the daily functions needed for life. A single blinded trial with 6 months of follow-up Tai Chi improved balance and decreased falls. Parkinson's patients participating in Tai Chi showed improvement in non-motor symptoms, motor function, and improved quality of life. They were more likely to continue physical activity than those who participated in strength training or stretching. And so you not only have the challenge of getting people to exercise, but if they can't find something that they like doing, they won't stick with it very long, particularly when you're as challenged as the Parkinson's patient is with movement in general. Some studies show small benefit and some don't show much at all, but Tai Chi is inexpensive. There's no reason not to do it. And any movement that helps the person stay balanced, build some balance, coordination, prevent falls, and that sort of thing is good. Qigong is an Asian practice that combines the practice of meditation and focused movement in order to move energy through the body. It's not very well researched for Parkinson's patients, but we do have one non-blinded randomized controlled trial that showed short-term improvement in motor control and quality of life as compared to controls. The effect was not sustained over time, but that really is meaningless because there is no carryover effect of exercise if you stop it. In other words, wouldn't it be great if people could exercise until they were 30 years old and sit back and they just could live forever with, you have to keep doing it. So that's not a particularly meaningful thing, but it was reported in the study. Only one high quality trial. It didn't show Qigong to be better than aerobic exercise, but the Parkinson's patient may be willing to do Qigong more than aerobic exercise. And by the way, the exercise that somebody will do, I said this before, becomes very important. So finding something that the person will stick with, whoever the person is, whatever age they are, and whatever they're afflicted with. Participants randomized into either an agility boot camp or treadmill training 4 times a week for 4 weeks. Both showed similar improvement in function in turn duration, stride velocity, peak arm speed. These are just all measurements of the progression of Parkinson's. Patients participating in physical activity showed improvements in cognitive functions as well. And part of the reason for that is exercise stimulates the production of something called brain-derived neurotrophic factor. And it's one of the reasons why exercise is such an important thing for people recovering from addiction and alcoholism and that sort of thing. Exercise does really make you smarter. I exercise almost every day. It's why I'm so smart. I'm just kidding, actually. 15 participants with Parkinson's disease completed 16 weeks of high-intensity exercise training. The objectives were to address strength, power, endurance, balance, and mobility. There were improvements in body strength, leg power, single leg balance, sit-to-stand motor unit activation. Remember when I said earlier, getting up out of a chair is very challenging for patients. Parkinson's disease quality of life scale, and fatigue severity. All good things, right? Systematic review of 33 randomized trials with over 1,500 participants. A wide variety of things ranging from just general physiotherapy to treadmill to martial arts, etc. And everything improved. No particular exercise was better than another. And in my opinion, the exercise that is better than another is the one that the Parkinson's patient or whoever we're dealing with is willing to engage in. No benefit was observed for falls or patient-related quality of life in this particular review, but some exercise is better than others. Like yoga is really great for building balance and coordination. And so whether you have Parkinson's or not, you might want to consider doing it because it's a great form of exercise that promotes healthy aging in that it improves balance, coordination, and strength, all required for living independently. And here we are, yoga. It's particularly helpful for Parkinson's patients because it can be adapted to any level of disability. And it targets things like flexibility, strength, alignment, and stress. There are a million types of yoga. You can find something that everybody can do. There's chair yoga, there's wheelchair yoga. I mean, anybody can do it. And research has shown that Parkinson's patients get better with yoga. Full disclosure, I own a hot yoga studio right across the hall from my office here. So I'm a fan, so much so that I bought the studio that I took classes, where I took classes and moved it in here. Acupuncture, lots of research showing that it's helpful in many, many things. Ability to walk, speed of walking, step length. Remember the Parkinson's patient, I said earlier, sometimes take shorter and shorter steps. Sleep, rest, handwriting, depression, anything that helps with depression is good, because depression often makes the Parkinson's patient just give up and not want to do anything for themselves. And the MRIs of Parkinson's patients show that the restorative effect may be due to the activation of other parts of the brain, which serve a compensatory role in correcting imbalances. And of course, the production of this brain-derived neurotropic factor. I have quite a bit of information in my bigger course on Parkinson's, but in terms of supplements, but the one that I think deserves some attention here is B12. B12 levels tend to be lower in Parkinson's patients, and B12 deficiency is associated with symptoms of Parkinson's and people who don't have it, like neuropathy and cognitive decline. Systematic review, neuropathy was present in 16% of Parkinson's patients. Vitamin B12 was identified as the likely cause. And so taking a B12 supplement is advisable. It certainly can't hurt in this case. I've advised against taking high-dose B12 supplements for the general population, but in a person with Parkinson's, particularly when dealing with neuropathy, B12 has been shown in some diabetes studies to be helpful with neuropathy. So no reason not to try it, because even if there are some side effects at higher doses, the side effect of neuropathy is eventually you can't move, right? The treatment challenges, I mentioned them before, include that the patients often can't adopt a health promoting diet, exercise, and access alternative treatments without help. So you need a family member or a friend to help. And we live in a society of people who move around a lot, and people often are not in the same place as their aging parents and that sort of thing. It can make it really difficult. Motivation is a factor, which I mentioned before. The person has to want to do better and they have to work at it. So the best success we've had has been when you've got family members who are willing to help out, and maybe friends from church and that sort of thing. But that combined with a Parkinson's patient who says, I'm just not going to let myself become disabled. And to the extent that I can overcome some of the disability I've already experienced, I'm willing to do whatever it takes to do that. So I think that the group that I'm speaking to here, you're probably on the same page that I am, or you wouldn't be in this group, that your mental attitude has everything to do with outcomes. I've seen cancer patients survive the most dire diagnoses, mainly because they've just decided, I'm just gonna do it, you know? So strength of mind becomes really important in all diseases, really. So the summary of what we've talked about, I flew through this because I want to be able to take questions and turn this into a discussion. But if you want to prevent Parkinson's, it's a preventable condition for most people. But if you have it, a family member has it, a plant-based diet eliminating dairy and high gluten foods, barley, rye, oats, and wheat, low protein, low fat, B12 supplement and probiotics, exercise, acupuncture, and then a lot of assistance without other people involved. The difficulties encountered by the Parkinson's patient who's had some progression are almost insurmountable. And unfortunately, when Parkinson's patients are placed in a care home, it's not usually with the idea of keeping them functional. It turns into warehousing. And those places are not built to do. I don't want to be too hard on them, because they're just not built for the type of intervention that would actually improve the outcomes and make the person better. That's just not what they are. So here's my contact information. My email address is pampopper@msn.com. You're welcome to email me if you're interested in learning more about what we do and that sort of thing. And I'll stop the share, and I'm happy to spend our remaining time taking some questions from the group. So I hope that was helpful for people.
We're certain it was, Pam. Thank you so much, as always. Thorough and meaningful and helpful. Yes, we're going to jump into our Q&A. Thank you for sharing your contact info there and inviting people to reach out to you directly. But just also, what about your book? Where's the best place for people to get that stuff?
You can buy it online. You can buy it at bookstores, or you can buy it here at the office. We'll even send you an autographed copy. So you can contact our office too. Thank you for asking.
Absolutely. Thank you. Okay, great. So we just want to make sure everybody knows how we go about our Q&A sessions here at The Real Truth About Health. And so you know this, but we'll make sure anybody that's new, down at the bottom, what we do is we typically don't take the questions directly from the chat box. We ask people to raise their hand and their virtual hand. And so the way we do that is, if in case you don't know out there, down at the bottom of your Zoom screen, you have different tabs. One of those tabs is called a reactions tab. You click on your reactions tab and some emojis will pop up, and one of them says raise hand. So you click your raise hand function. We will see the raised hands come in. We will know that you have a question for Pam Popper. We will take those in the order in which we receive them. And I'll go ahead and call out your name, and I'll unmute you when it's your turn. And so, Pam, we set them up, you knock them down, and we go from there.
Okay, great.
I see a couple of hands raised already, so I'll just jump right in. And I hope I'm pronouncing your name correctly. It looks like Ravendra. I'm going to unmute you now. Welcome.
Okay. My 88-year-old partner has Parkinson's, and he has extreme fatigue and weakness, and he's become vegan for a year and lost 30 pounds just from low fat. And the question we have is how to overcome the fatigue, and if the muscles are losing their muscle mass, would low protein aggravate that situation, or how to keep the muscles maintain their mass and build their strength and build the fatigue? The partner support is not as helpful if the motivation and their fatigue is holding them back from doing the thing that you're advising.
Yes, I understand. Thank you for the question. The first thing is that diet is a very important intervention. And just to put this in perspective, the average adult takes in 1 ton of food per year, a ton. So think about how big that is. And so when somebody says that it doesn't matter, in what universe does a ton of anything not matter, right? Of course it matters. So that's a really important step, is to eat a low-fat, plant-based diet, high carb. The next thing is to look at hydration, because even a healthy person, if you notice, I've got my water here, right? I'm always drinking water because I talk all day long, which is actually, if you go out in the cold and you see the vapor, that's loss of water, right? When it's really, really cold outside. So on a day like today, when I'm talking all day long, I've been talking since like 8 o'clock this morning, I have to stay hydrated. If I don't, not only is my mouth dry, but I start to get tired. So hydration is something to look at. Being sedentary makes people tired. One of the first things I'll do, like if I'm at a conference or whatever, and there's just so much going on, I don't have time to exercise, like what happens when we have conferences. The first thing after everybody goes home, it's like, I got to go get on a treadmill or go out and run or go do something before I just fall asleep on the floor. So physical activity will help, and physical activity will also be the key to building muscle strength, which is the key to being able to live independently and move around. So when you've got somebody who's really weak, I would pay attention to the hydration, make sure the person's eating enough food. That's another thing too. Calorie adequacy is an issue. Make sure the person's eating enough food, and then begin to do movement, and start putting movement into the equation, but start where the person is. So if you've got an older person who is really weak and tired, we're not going to go to try to do a 4-mile walk today, right? I mean, I've had people start, they're so out of shape that the first time they walk, they go to the mailbox and back. Maybe they do that for 2 or 3 days. Then they go to the mailbox and turn left and go to the end of the cul-de-sac and come back. It can be very, very slow, but I think you'll see a lot of improvement with very gradual incorporation into more and more movement. And that will help with the brain, as I mentioned before. And it will also increase energy levels over time. And it's the key to independence, because if this person just continues to sit, the disability will be the inevitable end, in spite of the good diet.
Thanks very much for that, Pam. And we're going to move on now to our next question coming in from, let's see now. Steve, I don't see audio for you, but if you can get your audio fixed, we'll come back to you. So I'm going to go on now to somebody with the initials JB. JB, welcome.
Hi, Dr. Popper. My husband has Parkinson's and has severe constipation. He takes the Linzess every day, the larger amount, 290 milligrams. Sometimes that's not enough. He is on a plant-based diet. He drinks plenty of water. He takes peppermint oil, which helps when he needs it. But I've heard that some essential oils are bad for the microbiome. Is peppermint oil safe for him?
I think the peppermint oil is safe, but you might want to start a probiotic as well. In other words, a chronically constipated person has pretty much destroyed their microbiome. And it can't repair itself because the bacteria that populate the microbiome the body doesn't make them. It's an interesting thing. All creatures on the planet have microbiomes. Even a fruit fly has a microbiome. It's much smaller than ours, I might add. But in any case, this really is creatures that these bacteria can live on their own without us. We can't live without them. And if you get to the place where you've destroyed enough of it, a probiotic might be helpful. The other thing is, again, I'd look at water. It is shocking. I bet probably 75% of the people who I talk to, the first time I talk to them, they are not drinking enough water. And the key to resolving constipation is that you need a high fiber diet absorbing all that water to put pressure on the colon and cause a bowel movement. One last thing I'll mention to you is if people are taking laxatives or prescription drugs like Linzess to have bowel movements, over time, sometimes those drugs can be withdrawn as the microbiome is replaced and the water drinking and the high fiber diet and all that take hold. But these drugs are highly addictive and the laxatives are highly habituating. So you have to withdraw from them very, very, very slowly. You can also add a little bit of magnesium. You can experiment with some magnesium, which often gets the bowels to move as well, and might get your husband off the Linzess.
Thanks very much for that, Pam. And actually, it looks like Steve's got his audio fixed, so we're going to go straight to Steve. Hi, Steve. Welcome. Oh, Steve, are you there? So hang on, let me try to unmute you one more time. Okay, Steve, I've unmuted you. Are you there? Okay, Steve? No, okay. So Steve, something's still going on there. If you can try to work on that, we're going to take a few other questions and hopefully we can get back to you. Thanks for trying. We're going to move now to Eileen. Eileen, I am unmuting you and welcome.
Hi, Dr. Popper. I don't have a question. I just wanted to tell you how much I admire you for everything you've done, especially this past couple of years. I've been listening to you and I just think you're a kick-ass woman. I can't think of any other thing. I just think you're great. So I just thought I'd tell you that.
Thank you. I always wanted to be a kick-ass woman. So I'm
You did
glad. Thank you.
You're welcome.
And thanks for that, Eileen. And we're fond of Dr. Popper as well. That's why we keep bringing her back. So thank you for being here again. And I see now that we have Ben. Ben, I'm going to ask you to join in.
Yeah, can you hear me?
Yes.
Can you hear me? Thank you very much for your teaching us today. And I got one question. I saw you said slides, high fat can damage the mitochondria. The high fat is come from the avocado or any The high fat, I don't understand here. High fats.
What's that now?
High fats. You said mitochondrial dysfunction can cause by high fat food and inflammation. You said high fats. High fat.
High fat. Yes.
Yeah.
High fat diet is very damaging. High fat diets are a problem in so many respects. I mean, if you eat enough fat, you can increase your body's production of cholesterol. And if you eat too much fat, it slows digestion. It's one of the leading causes of slow digestion. I mean, that's one of the reasons why people will sometimes eat lunch and then they're not hungry until 7 or 8 o'clock at night. It's because they had a high fat lunch. It just takes forever to go through the system. And then of course, fat contributes to weight gain. I mean, it's very difficult to maintain normal weight when you're eating, for example, oils that have 14 grams of fat per tablespoon, right? They're just weight promoting. So really, whatever topic the lecture is, today it's Parkinson's disease, tomorrow it could be something else, you're still going to get the same recommendation to eat a low-fat diet, high fiber, low fat. And the one exception would be if you have some reason to eat a ketogenic diet, you have an epileptic 3-year-old or brain cancer. Those would be some indications for a high fat ketogenic diet. But other than that, you want to keep fat intake really, really low. And it's not hard to do once you learn how to do it. In fact, what most people experience if they eat a lower fat diet long enough was when they eat too much fat, they don't feel so good. And most of it, and I can tell you that from my own experience, it just feels like the food is just sitting there. Don't sleep so well, that kind of thing. So most people like it better once they can make that conversion. And it will help in this situation. It will particularly help the constipated PD patient.
Thanks, Pam. Looks like Ravendra is back with a follow-up. Let's go ahead. Welcome back, Ravendra.
Okay. Thank you for giving me another chance to ask another question. Drinking water is just like cleaning. Everything to clean, you need the water. But if you have bladder issues, like my partner gets up 3-4 times at night to urinate, on a good day he may not get up any time, but that is an issue. And if during the daytime we go anywhere and if the water is asking the bladder to go and you cannot go, there is a leakage issue. And if we take medication for urgency, that doesn't help the brain. How do you suggest we address this bladder who's not happy if we drink water?
Well, one thing I'll mention is that the further the progression goes of the disease, the more difficult it is to incorporate the things that we're talking about. All right, for the reasons that you're stating, you bring up a very good point. If the person has difficulty with bladder, which is common, as I mentioned in the lecture, then the water drinking can become problematic. A couple things that you can do. One is bladder retraining. Teaching people can learn to control how long they can wait before they urinate. Another thing is you can time water to stop drinking before bedtime, a few hours before bedtime, which makes it less likely that the person will get up during the night, which would lead to more restful sleep and the potential for having more energy the next day. But one of the difficulties in doing some of these things is with a late stage patient who's already down the path of medications and certain disabilities, you can't always overcome it. And another thing too is the ability, it may be that going someplace you do have to wear Depends or something of that nature so that you avoid leakage. I would rather see somebody wear Depends and have some leakage than not drink enough water based on a long-term view of what this disease looks like as it progresses. But these are the kinds of discussions that you need to have with somebody. It's obviously I'm a little bit of a disadvantage because I don't have all the information on the affected person here. I could just give you some things to think about.
Thanks very much, Pam. And we're going to give Steve another shot. Steve, I am unmuting you. Are you there?
I'm here. Sorry about that, Ben. I need a
Great.
technical team like you guys have. Hi, Dr. Popper. So nice to see you again.
Thank you. So glad that you're here.
This disease is horrible. I mean, there was a gentleman that I took classes with, and one day he was there, and then the next day he was still there, but he couldn't communicate.
Mhm.
And can you tell us a little about the hallucinations that he was having?
Well,
And I would sing with him old TV theme songs, and all of a sudden he would sing with me, and he was back. And then as soon as we finished, poof, he was gone. This is
yeah, well, cognition is a major problem for Parkinson's patients, and it's a major problem. I mean, when you look at the incidence of Alzheimer's disease in this country and cognitive decline, I mean, it's awful to say, but one of the best investments if you're making a stock play is memory care. And doesn't that say a lot for where we are in terms of aging well in our country, right? But remember that Parkinson's disease is a disease of the brain to a certain extent. That has features all over the body. So the reason why the person might recognize songs and sing with you and then just retreat back to the old state is that the ability to initiate that kind of thing goes away over time. And the hallucinations come about because of the effect on the brain. So unfortunately, hallucinations are a major part of the condition, and it can be one of the contributing factors to why the person can't stay in his or her own home anymore, because it becomes increasingly difficult for, just think about the things we've been talking about here. You've got urinary incontinence, and you've got hallucinations and loss of cognition. The person will get to the place where they can't be left alone and can do very little for themselves, and it becomes very, very taxing for the family. But these are all just normal things to be expected as the disease progresses. And one of the reasons why you want to do as much as you can early stage to keep it from getting worse for as long as you possibly can.
Thanks very, very much for that, Pam. And Ravendra is back for another one. So let's go ahead and unmute her. Welcome back, Ravendra.
Yeah, no, I just in relation to, like you mentioned, acupuncture helps. Would hypnosis help?
I don't think so. And one of the reasons I say that is, first of all, I've not found anything that shows that it helps, and it doesn't. I can't imagine what the mechanism of action would be. And there has to be a mechanism of action, right? I mean, I don't think it would hurt to try it, but I would be surprised if it helped, because it basically doesn't solve the problems that we're trying to solve, which is, the blood-brain barrier and the gut microbiome and that sort of thing. Having said that, there are some things that I don't spend much time talking people out of, because you never know, and there's not much harm in trying. Unlike drugs, drugs and surgery, there's always a downside, and sometimes the downside is pretty frightening. But if you were to take a family member for a couple of hypnosis sessions, worst case scenario is it may not work.
So Pam, that is actually the last of the raised hands that I see right now. But if it's okay, I want to take this in as well. I was just going to say
more.
like direction, but we've got a few more now. Okay.
All right. Happy to take them.
I will table that, and let's go to let's see if I hope I have your name right. Welcome. Toya.
Hi. Nice to be here. I have a question. It's not really about the incontinence. It's about I get a lot of UTIs, and I was told I can take the tablets, the cranberry. I wanted to know if I can just do, because I'm plant-based, if I can just do the juice, like the fresh pressed, instead of the tablets.
Yeah, you're much better off with the fresh press. But if you get the constant UTIs, that means you probably need to take a strong probiotic, and you have to break the cycle of antibiotics, regardless of whether it's associated with Parkinson's or not. You have to break the cycle of antibiotics, and sometimes we'll use plant antimicrobials in place of antibiotics. And often, if you catch it early enough, you can do that, so you can stop this destruction of the microbiome, which makes it easier to get another infection, and so on, because the chronic infections mean something is wrong, and what you want to do is fix it. But yeah, the juice, the actual fresh pressed juice, or a juice not from concentrate, is much better than taking the tablets.
Thanks, Pam. And we now have, let's see, hopefully I'm pronouncing your name correctly. Is it Kaylee or Kylie?
It's Kaylee. Hi, thank you. Hi, Pam.
Hi.
Hi. Please, if we've determined that the blood-brain barrier is basically broken, it's intruded upon. That's nice. Is there any way to repair it?
Yeah, you stop injuring it. Yeah, I mean, as silly as that sounds, that you stop assaulting it. You do that with changing the diet, improving cardiovascular integrity, which is from changed diet. So yeah, everything is theoretically fixable. The earlier stage it is, the easier it is to fix it. It's like a car. It's easier to maintain a car and to fix minor things that go wrong than it is to wait until the car won't move anymore and then take it in. Bodies are not a whole lot different, but yeah, you can restore integrity to a leaky gut, and you can restore integrity to a blood-brain barrier as well.
Thanks very much for that, Pam. And Ravindra is back. Let's go ahead and unmute you. Welcome back, Ravindra.
Yeah, thank you. The question is, in the acupuncture, the auricular microcurrent acupuncture will do the same as needle or laser or
I think you want the needling. We've had the best experience with acupuncture here in Columbus with using well-trained acupuncturists trained in traditional Chinese medicine. There are two particular practitioners we send people to here in Columbus that do a good job. Having said that, not that this is the same as humans, but I have an almost 18-year-old cat who has a lot of health issues, and he gets acupuncture every other week, and he gets both laser and needles for different things. And the laser seems to have a great effect too. So that's not I'm not a traditional Chinese medicine. I'm not trained in TCM, but I've referred a lot of people to acupuncturists, TCM trained acupuncturists for treatment for a lot of conditions, including Parkinson's.
Thanks very much again for that, Pam. And so, Ravindra's back again. Let's see what you got this time, Ravindra.
Okay. Would the infrared light therapy or microcurrent to the scalp that was developed in Harvard, that you put a helmet which has microcurrent and it stimulates for 30 minutes, their measured amount of amperage and duration of stimulation. And similarly, the infrared either pads to which have less electromagnetic field, or going to an infrared sauna with less electromagnetic field, would that help Parkinson's disease of my partner?
Not that I've seen. Again, there's not much wrong can go with that. But I think the thing you have to be careful of is almost all conditions with severity, like Parkinson's or cancer, you can spend all day running around after alternative treatments. It can be a full-time job. And so most people have limited money. I mean, there's not unlimited funds. Like, we can just chase after everything. We will start at 8 in, and we will do every alternative thing we can do. Most people can't do it from a time and money perspective. And the other thing is that you wear out the patient. So I would tell you to focus on things that have been demonstrated to have high impact. Exercise has high impact. And what I would hate to see is somebody sitting in the sauna and going here and there and everywhere. They don't move other than going here, there, and everywhere. That would be a colossal mistake, in my opinion.
Thanks for that, Pam. And we now have a new question in from Stacy. Stacy, I'm going to unmute you. Welcome, Stacy.
Hi, Pam. Thank you so much for your awesome work, first off. And second off, do you know any benefits of juicing hemp or cannabis leaves for just the balancing of the human body in general?
No. And by the way, balancing the human body is such a general term. If you want to balance the human body, you have to take care of the human body on a daily basis. That's your diet, exercise, water, social interaction, quality of life, purpose, sleep, hydration, all that kind of stuff, right? That's so those are the things that balance your body every day. And if you're going to use something for this would be a medical intervention, what you're talking about, and then you would want a good reason for doing it. In other words, the risks and the benefits weigh out. And also, I'll come back to this too. I've mentioned it a couple times, sort of in passing. And that is the importance of getting people to do things long term. I don't like to see people tied up with busy work because it leads to that's the reason I don't push the vegan, because it's not necessary. But the other thing is I am much more interested in something that somebody can do for a long period of time than this short-term burst of hysterical activity that goes away after a while. So I want to use up the compliance genes on the stuff that really matters from a strategy standpoint. I hope that makes sense.
It certainly does, Pam. Thank you very much. And I thought we had somebody, but it looks like, yep, Ben is back. We're gonna have Ben unmute. Hi, Ben, welcome back.
Yeah, I'm sorry. I ask. Thank you very much for the time. You talk about water fasting. So how can the patient do the water fasting?
If you're going to use water fasting as a therapeutic, you need to do that in a fasting center. There's several of them around the country now. Fortunately, they're more opening. So you would want to do this in a residential facility. Whether or not a Parkinson's patient can fast is an issue because it depends upon medications and that sort of thing. So not all people are candidates for water fasting. But I've probably sent 500-600 people to fasting facilities during my last 20-some years I've been in business. I'm a fan, but you have to do this in a residential setting for safety purposes, and the patient has to be interviewed for suitability for fasting based on the drugs that they're taking and that sort of thing as well.
Excellent. Thank you very much for that, Pam. Pam, I think that was our last question. I just was wondering if you could touch on something real quick. And I don't remember who it was. Somebody asked you earlier about something and you sort of said, well, I'm not, entirely sure whether I believe in that. Ultimately, what you were saying is you were looking for evidence-based rationale. And so I wonder if you could just touch for a minute before we close, because I know you've spoken about this before, on the importance of evidence-based health information for all of us.
Yeah. So the first thing I want to say is evidence-based is the thing, but the problem is that 95% of what's in medical journals is garbage. So you have to tease out the 5% that isn't. And the way that we went about that when we started a few decades ago, I can't believe I've been at this for a few decades. So now is when you tell me I don't look old enough to be doing this for a few decades, right? But
that's exactly. I was thinking
anyway.
that.
Aside from all that, what we tried to do was to bring some type of order to evaluating information. So we have 19 criteria. I'm not going to list them all here, but we basically look at conflicts of interest, which they almost all have some right now, and selection bias in the cohort, things that are statistically significant but meaningless to the patient. In other words, statistical significance means that it made a difference. But, if you get 5 episodes of chest pain per week instead of 6, does that change your life? No. So why bother? The risk-benefit ratio, we look at number needed to treat data. The confusion between correlation and cause and effect relationship. I mean, the whole vitamin D hysteria is based on converting a correlation to a cause and effect relationship, and there isn't one, as it turns out. It was misinterpreted. So we teach all of our clients how to do this. We teach our health professionals how to do this when they enter training in our school. because it's like football. I teach their analogy. You know, if you just said, listen, here's how we're going to play football. We're going to have teams show up. They're going to run up and down the football field with a football for an hour, and then we're going to try and figure out who won. My gosh, it'd be total chaos. But because there are rules, the quarters are 15 minutes. The first down is always 10 yards. And to kick a field goal, it goes through the post, right? The post. All right. So at the end of a season, you can play thousands and thousands of games of football all over the world. And we maybe fuss and argue about 5 plays, 10 plays, 12, maybe, right? Because there are rules. And so the key is to use rules when you're evaluating evidence, so you don't get into the way people usually talk about health, which is, I call it the tribal method. He said, she said. And then I read an article, you read a different one. I saw this book, you read it. I went to this website, you went to a different one. You know, I just saw this doctor, you have a different one. And then my uncle's best friend's neighbor's boyfriend's wife says, okay, so you know what I mean? It's hard to make sense of all of that. So I'm looking for high impact stuff. You know, when I mentioned before about some of these are complicated diseases, and people have so much time, so much money, and so much patience in some cases. So you better make sure that the things that you're doing really matter, so that you don't waste a whole lot of time on stuff that doesn't, just exhaust yourself without really making any progress. Because then, particularly like with a Parkinson's patient, bringing it back here, you've got a person who may be difficult to motivate in the first place because life is just difficult, right? We don't want to make that any worse. So I hope I answered your question, but.
You did. I know so many of us are probably thinking, okay, so, you know, you have a great way to do that, or as skilled as anybody at doing that. How do we, the lay people, navigate that? And I don't know if you have any other specific suggestions around that. Or...
Well, maybe that'll be one of next year's lectures, is I'll give a talk about how to look at information and interpret it, because it really pertains to everything. But I think here's something I can say that is really helpful for everybody. If you just did nothing else but this until I come back next year, right? So a guy by the name of Dr. Pam Popper, who's not a relation of mine, darn it, because he was so smart, right? I'd love to claim him as a relative. He lived in the UK, and he was the person who pioneered, he was a scientist and philosopher, and he pioneered the idea that you falsify the hypothesis. In other words, what most people do is they hear a new idea and they jump on it. It's the best thing. I'm going to do it. You should do it. Everybody should do it. Whatever it is, right? Okay. So how about if you did it differently? How about if you said, here's a new idea. I'm going to assume that it's false. I'm going to try to prove it false. And if somehow it survives that and it turns out to be true, my gosh, we'll know we're onto something, won't we? Okay. And so I think that one of the biggest problems that people have in trying to sort out health information is that tendency to hear something new and go, that's it, I'm going to do it. Somebody says, go sit in a sauna, I'm going to go do it. Somebody said cancer patients benefit from this, I'm going to go do it. You know, and I understand where that comes from, but that impulsive chasing after everything is exhausting and inexpensive, and it often doesn't lead to very good outcomes. So just take a breath and don't be so quick to jump on everything. And by the way, another thing I'll mention, you know, I've told Steve should raise his prices. The fact that you guys get this for $7 a month, you can sign up for membership. If you don't sign up, you're nuts. All right. Because one way where you can learn a whole lot of new stuff is right in front of you to become a member. So don't neglect to do that.
Well, we appreciate that. Thank you, Pam, and very sage advice with everything that you said. And thank you for everything you shared with us today. Incredibly valuable for all of us. It means a lot. We're glad that you are always coming back with us. I know I want to thank you up and down. And I think you know that we want to unmute our audience because I think they want to say thank you as well. So everybody, what do you want to say?
Thank you very much.
Thank you.
Thank you.
Thank you.